Hello friends, welcome to yet another episode of Scientia, the public health podcast, an esteemed endeavor towards health communication by the postgraduate students of community medicine of Puducherry Medical College and Research Center. The goal of our podcast is to bring about the scientific temper on public health domains and provide a platform for regular exchange of views and information. I am Dr. Dency Davis, PG Resident from the Department of Community Medicine. Today we are delighted to have Dr. Sanjeev Nair, a distinguished figure in the field of pulmonary medicine with us. Dr. Sanjeev Nair serves as a professor in the Department of Pulmonary Medicine at Government Medical College, Thrissur. His contributions extend beyond his role as a professor. He holds several significant positions, including the chairman of the Zonal Task Force for Medical Colleges of South Zone. Additionally, he chairs the state working group of latent TB infection in Kerala and serves as a subject expert in the National Technical Expert Group for NTEP. Dr. Sanjeev Nair's proficiency also extends to his involvement as a member of Global Burden of Diseases Chronic Respiratory Disease Group representing India. Furthermore, he is a president-elect of Academy of Pulmonary and Critical Care Medicine. We extend our warmest welcome to Dr. Sanjeev Nair to Scientia. Welcome, sir.
Thank you.
Sir, before going to any specific topic, is there any inspiring story behind the evolution of your career from being a pulmonologist to a public health expert?
Yeah, I guess I'm more of a clinician rather than a public health expert, but then I've been working with public health for the last 25 years. It's a long part of my career. I've also been working throughout as a public health physician. So I do have that experience. But then, I started out and out as a clinician. And the initial part of my career, I actually blundered into public health because I was posted in Idukki district in Kerala, where there was no other specialist in my specialty. And the administration was forced to make me the district TB officer of Idukki. But once I took up the job, I really fell in love with it. In fact, even during my pre-MD times, I was interested in public health, but it was peer pressure which made me take up a specialty other than public health. So once I got in as a district TB officer and started doing public health work, I really enjoyed it. And for some reason, I think my work was appreciated, particularly because once Idukki implemented the RNTCP, that made Kerala the first state in India to have implemented RNTCP in all the districts. In fact, that was in 2000 December. The rest of the country actually took another 6 years to completely implement it. It was a very long drawn process. But I think my work more into public health started when I joined WHO in 2003. So once I joined as a WHO consultant, I walked in with, I thought I had enough knowledge about tuberculosis as a technical expert, but I did not have much of expertise in any other area. I thought I did have some expertise in data analysis, which was my strength. So bit of data analysis, strength with numbers, and then some knowledge of TB. But then once I walked into the job, I realized that even my knowledge of TB was insufficient. So I kept learning. But one of the skills which came up very fast, which was noticed even during my training, was my ability to, pick up mistakes and maybe pick up data fudging and all that. So I walked into that and, I started picking up mistakes. And my very first training visit to one of the districts near Delhi, uh, during the field visit, while everybody else was looking at the data, uh, I realized that there was something wrong with the way the lab technician was doing microscopy there. And interaction with the lab technician and talking to the lab technician and the assistants and everybody there, I suddenly realized that the young boy, about a 17-year-old boy running around in that lab, was actually the person who was doing the smear microscopy there. Whereas the lab technician, who was his uncle, absolutely had no skills in doing a microscopy at all. And nobody, including the district officers, knew that that was happening in their lab. And I could pick that up and part of a supervisory visit. So from those days, my supervisory skills were appreciated, and also, in fact, my boss, the then boss, who was based in WHO Delhi, he was a bit frightened that I was picking up things too fast, which maybe, in a way, that was true because later I started picking up a lot of data, my falsification, and I reported it, which also led to trouble. So it's public health, it's a double-edged weapon. Many of your skills are double-edged. So on one hand, you have skills which which are good, which are needed, but on the other hand, that can also get you into trouble. So I got into trouble very early in my career as a public health specialist because I started picking up falsification of data, which was still then not picked up. That led to a lot of trouble for many of the administrators, and I thought that was the end of my public health career and that I would be going back to my clinical work. But to my surprise, that work that I did, finding out falsification and reporting it despite facing a lot of adversity, that made me known at national level, and I started getting more opportunities, and then I started, being pushed forward more because the program thought they needed some, they call me a strong man who would not bend to pressure and all that. So that is also needed. So from there, I think my once I started whatever I did, I was thinking that what I did would actually lead to me being forced out of the job and going back to my clinical job, but rather it led to me being roped in for more and more work and more and more challenges which I could take up, and that I think it was a slow transformation, but what I can say is that you get ample opportunities to learn. That is what I've always felt. Um, as a public health specialist, you get a lot of opportunities to learn. Nobody goes in with all kind of knowledge. Often after finishing our MD, whether it's a clinical MD or a public health MD, one assumes that you know a lot of things. But it's only while you're working on the job that you realize that uh, there is still so much to learn, so much of practical things to learn. And as long as you keep yourself open to learning, you can learn a lot of things and gain new skills, and the opportunities always would be there. In fact, what I would recommend is, like some of the colleges taking candidates for MBAs, they would prefer that a candidate comes after working for 2 or 3 years rather than coming immediately after their BTech or their MSc or MA or whatever. They would rather want this person to work in the industry for 2, 3 years so that they come with some practical experience and they know what to expect from an MBA course. Similarly, even for public health specialists, I often feel that it's often better if that person has worked, say, in a primary health center, in a in all levels of maybe at the directorate and all that, and then goes in for a job, and that person knows how much to expect, what to expect, how the system works. So I think that is very crucial. So one of my strengths, which I always talk about whenever I go in for public health meetings, that I worked at every level, starting from a primary health center to a district TB center to a taluk level hospital to a district hospital. I've also worked at the state headquarters at state TB cell and directorate in Trivandrum. Also worked for a month at Nirman Bhavan in Delhi. I worked with WHO. I worked with medical colleges. The only sector in which I have no personal experience is a high-end tertiary care private hospital. So I say that my wife works there, so I get indirect experience from her as well. So the entire spectrum of personal experience there, which helps me to do whatever I do in public health. So I don't know if I answered your question.
That was really inspiring, sir. That was a great journey. Your expertise extends to latent TB infection as evidenced by your role as a chairman of the state working group for LTBI in Kerala. What are some of the key considerations and strategies in managing latent TB infection, particularly in a high burden state or setting like Kerala?
Yeah, I guess Kerala is well placed in terms of having the lowest prevalence of TB in India by a far way. So when the prevalence of TB in India is in the 300 per lakh range, 300, whereas many states in India are even at 500 per lakh population, Kerala is at 110 per lakh. So we are at the bottom of the list in terms of pulmonary microbiology confirmed TB. Now, so we need to go further. The same strategy we were doing earlier may not actually help us in our efforts to meet some of the NTB targets. In that context, it's inevitable that we have to do TB infection management, called programmatic management of TB infection these days. But of course, it's not something easy to do. Starting from developing a strategy to implementing it, each stage of it is quite difficult. The problem obviously is that managing TB infection is not very easy. It's not like giving a vaccination for COVID. Even when you give a vaccination for COVID or any of the communicable diseases, that itself leads to a lot of resistance and people not being willing to do it. Here, you have to test, you have to find out the people who are infected, and then the treatment lasts for like 3 months to 6 months. So it's a long treatment they have to take when they're totally okay. So, there the challenges lie. So our challenges in the state obviously are in getting enough capacity for testing the eligible people. Some of the groups need not be tested, like children below 5 years or HIV positive individuals need not be tested; they can directly be treated. The second challenge, obviously, is one of the major, wrongs you can do when you are managing TB infection is if you are not ruled out disease and you think somebody who's infected does not have disease and wrongly treat him for a infection, you can create drug resistance. So that you need a lot of capacity to rule out TB, which is very difficult. Diagnosing TB is easier than ruling out TB, and obviously starting treatment and ensuring patient takes a full course of treatment, ensuring the logistics of test kits and drugs. So all these challenges are there, but obviously if you want to reach certain targets, you cannot do it without doing all
That was really informative, sir. As a subject expert on the National Technical Expert Group for National TB Elimination Program, you contribute to shaping the national TB policy and guidelines. What recent policy developments or initiatives are you particularly excited about, and how do you envision them impacting the TB control efforts in India?
I guess I'm more into the treatment group of the National Technical Expert Groups, and TEG treatment is where my role comes in. So, what excites me is the newer regimes that are coming in. So, internationally, as you might be aware, until recently we used to say that the minimum treatment for TB, for drug sensitive TB, is 6 months, and for drug resistant TB, we should talk of a shorter regime, which is 9 to 11 month regime, and a longer regime, which is 18 to 20 month regime. Whereas now, internationally, WHO has also endorsed shorter regimes for both drug sensitive and for drug resistant TB. So, the drug sensitive TB regime that WHO endorses now is a 4 month regime. And for drug resistant TB, it's actually a 6 month regime. In like 10 years back, if somebody talked of treating drug resistant TB in 6 months, nobody would have believed that person. So, now you have newer regimes available, newer drugs which allow you to complete treatment in 6 months. Now, these regimes are available. Many countries in the world, like the USA and all, have already adopted these regimes. So we are waiting for our country to take up these regimes to see how these regimes pan out. So the National Technical Expert Group has been in discussion in formulating some of the guidelines for this. But obviously, this involves new drugs, and these drugs need to be procured. So there are a lot of logistic issues in implementing the regime. So I'm looking forward to that. Other than that National Technical Expert Group regime part, something that is really exciting for me these days is that the country is now building centers of excellence for TB, particularly FDR TB. So many centers of excellence have been identified, and the country has identified there are two areas where the country sadly lacks. Uh, and One is pulmonary rehabilitation for TB, and the other one is palliative care for TB. These are two areas which were never addressed in our country, and now that we are all working together to build consensus guidelines on how to do pulmonary rehabilitation in TB patients and also how to do palliative care in TB patients. And I think these two things will really do a lot of good to TB patients, which areas which were not addressed so far for the last so many decades. So those are new areas which are being taken up, which is also very exciting, which I feel will make a huge difference over TB.
Yes, sir. Sure, sir. We hope the new initiatives will be a success again. With only 1 year left until 2025, India's progress towards achieving the goal of eliminating TB, as outlined in the National Strategic Plan 2017-2025, is under scrutiny. Can you provide insights into India's current status in this final stretch towards achieving the ambitious objective?
Yeah, I think when the targets of you know uh, tar- whatever targets are set for what we currently call the NTB strategy, that is what we are working with. So we got targets for the NTB strategy, which is actually for 2035. So the 2035 targets were set by the WHO and the UN. Immediately following that, we got the Sustainable Development Goals (SDG) targets, which are 2030. Around that time, I think most governments in India started working towards reaching the SDG goals. I think Kerala was in the forefront for that. So our government also put in efforts to put up teams to develop strategies for various parts of the SDG, particularly health. So, I was part of the NCD group. We also had a COPD group, and we also had a group for TB. We started with that, but somewhere along the way, our governments felt that 2030 was too long a way back. So TB we should be doing early. So we are looking at the doing the Sustainable Development Goals as 2030 targets by 2025. So Kerala was supposed to be the ideally placed state for that. However, it's not very easy, and in between we got COVID also, which put a lot of setbacks to many states. In fact, many states in India there was a 80% drop in diagnosis during COVID period, so large number of patients are being missed. Kerala maybe missed only around 10% of these patients, but still COVID has hit us hard. During the COVID period, our patients were being diagnosed late. Mortality rates have gone up actually. In fact, gone up after COVID. More people are dying due to TB. So, for the Sustainable Development Goals, we are looking at three targets. One is reduction in mortality, reduction in incidence, and reduction in catastrophic expenditure. One would assume that in a state like Kerala with such a good health system, avoiding catastrophic expenditure should be easy, but that is not very easy. Every now and then you get patients who go through a lot of catastrophic expenditure. They go to all parts of India for treatment. To go, it's particularly extrapulmonary TB. You should understand that in Kerala, more than one third of our patients have extrapulmonary TB, much more than many other parts of the country. And if say somebody has a TB spine or somebody has a TB in the brain, and all lot of MRIs, surgeries, and all are required, which often are not available in the government sector and not subsidized. So people end up spending a lot of money. So we can't even assume that zero catastrophic expenditure which should have happened by 2020. For that, the target is not even 2025. For that particular one of the third three targets, the target year was 2020. I don't think that we have even reached zero catastrophic expenditure. For the other two, we were trying very hard to achieve the 2030 targets by 2025. World over, I think the achievement is much behind what was expected. So if you read the latest WHO report, also you will see that maybe where you're supposed to achieve 50%, we are still at 10-15%. So it's still a long way to go, even to achieve those 2025 targets. And now we are talking of 2035, 30 targets to be achieved by 2025. So it's not going to be easy. It's a long battle. I mean, if as public health specialists, bureaucrats and politicians do have slogans to give us, which are very important. So the slogan to achieve TB, the targets by 2025, led to a lot of funds and a lot of support for the program, which was not previously there. So in a way, that was good for the TB program and for TB patients. But on the other hand, as scientists and public health specialists, we have to understand the science and epidemiology of it, and TB control, TB elimination cannot be a short-term goal which can be achieved in 5 years or 10 years. We have to have a sustained effort over a period of time to actually achieve it.
So let us hope that India will be going forward with these efforts. Now, Kerala is recognized as a having a superior healthcare system compared to the other states in India, achieving a significant reductions in the infant mortality and maternal mortality rate. Additionally, Kerala recently earned the Bronze Award in 2020 and the Silver Award in 2021 for decreasing the TB incidence. Given these accomplishments, can we assert that Kerala is leading in the effort to eliminate TB than when compared to the other states in India?
Definitely, I think Kerala is in the forefront. Now, whether the elimination of TB would come in or not is a different question altogether.
Yes.
When it comes to the national picture, we are in the forefront. All experts in Kerala, including me, we are called by people from various parts of India, state TB officers and other leaders from other parts of India call and ask how we do certain things. So some of our strategies, we started our TB elimination strategies even before any other state in India actually even thought of starting it. So we started early. So it's just like a race. If you take it as a race, we had started running before people had even gone to the starting block. So we were far ahead, and we should always appreciate that this is not what we started doing in the last 5 or 10 years. This is a sustained effort since the RMDCP era, when many of our district TB officers and state level leaders, from the health minister, health secretary, down to the lowest worker at the field, ASHA worker or the multipurpose health worker or our own TB health visitors, STS and all, TLS, they have done tremendous work over the last 30, 40 years, which is now giving us the fruits. It's not something that we are doing recently and getting results out of. So we started early. We had a health system supporting us. Many other states in India, even if they want to do the same things, when they discuss the Kerala strategy, and they want to replicate it, they suddenly realize that they don't have a health system which could actually help them do all those things. So we have multiple advantages in Kerala. So many of the strategies we rolled out, like mapping of patients, panchayat level involvement. Again, the local government involvement in Kerala for TB elimination is one of the major successes which many of us have published. Sorry. But then we have to realize that replicating this in other parts of India may not be possible, because in many parts of India, the the Panchayati Raj organizations are not that well tied to health as in Kerala. In Kerala, panchayats have taken over the primary health centers. They have owning the primary health centers and many of the higher level hospitals. So it's a distinct advantage when you have a local government involvement in Kerala, which may not happen in other parts of India. So similarly, there are many inherent advantages in India with a good health system, good doctors, good healthcare workers, good involvement of the private sector. Private sector in Kerala is extremely responsible. So in many states of India, when I go, I am asked for help to get the private sector into the program. So I was telling one of my state colleagues, state TB officers, that in that particular state, the private sector interaction between the government and the private doctors was at the level where we were in 2001. So we are kind of 23 years ahead of that particular state in the kind of involvement. So today in Kerala, almost every private hospital is keenly involved in RNTCP or NTEP. And if you take MDR-TB, which is a big challenge in many states in India, almost all patients, 100% of patients in Kerala, when they have MDR-TB, they go through the PMDT system, which the NTEP runs. Nobody has any problem. The government or the private have no problems in doing it for the benefit of the patient. So those advantages are there. Despite that, we should understand that many states in India are now going far ahead of Kerala also. So it's not that Kerala is the leader always. You take our own neighboring state, Tamil Nadu has got a very ambitious program which looks at differentiated care for TB. There's a document called Differentiated Care for TB, which is there on the NTEP website. Unfortunately, that has not been disseminated well in India. So that differentiated care document actually says that there are a proportion of patients who need special care. It cannot be just, TB is domiciliary care. You're supposed to give drugs at home of patient, but still there are a proportion of patients who actually need more care than what actually can be provided through a ordinary domiciliary care. They have to be identified early, and they have to be provided a special set of services, which is also documented what should be provided. Now, that document has not been disseminated in most states of India, including in Kerala. The dissemination has been poor, whereas Tamil Nadu has gone ahead with the disseminated care in a big way. They have a name for that program in Tamil, which I can't pronounce, so I will not try to do it. But that program is doing well. They are identifying people who are very sick and about to die early, and their aim is to reduce the mortality rate. We should understand that Tamil Nadu is doing this at a time when the notified mortality rate in Tamil Nadu is lower than the notified mortality rate in Kerala. In fact, the notified mortality rate in Kerala is 8%, 8.1%, whereas the rest of the country has 4.2%. So we have almost double the mortality rate for TB in Kerala as compared to other states in India. So we were talking about the SDG targets. So one of the targets is reduction in mortality. So in fact, Kerala mortality still remains high. So the awards that you are mentioning were related to reduction in incidence. And you should understand that we have not done any incidence studies at all. These are all based on notification and some other indirect measures. The incidence is something we don't know for India. I mean, what is the incidence of TB in Kerala? What was the incidence in 2015? What is the incidence now? We have only indirect estimates of that. We haven't even done a state-specific prevalence study, which Tamil Nadu is doing. In terms of diagnosis, the National TB Prevalence Study has shown that X-rays are the most important way for TB in the future, because 50% of patients can be diagnosed only if X-ray is taken. You based on a symptom screening, which is what currently we are doing in our state and many other states of India, you will not pick up 50% of your cases. So X-rays are needed. Tamil Nadu has a huge, number of X-ray vans which can go to villages and take X-rays and all. We still have to invest in that. So many ways, many of the states. So Kerala has been in the forefront. We were the leader for a long time. We still are the leader in certain other aspects. But we should understand that many states in India are today overtaking Kerala in many ways. Even states in the north of India, like Haryana, has got a very good network of microscopy centers, culture labs, and all that. Kerala is still stuck with only 2 culture labs, so which cannot actually meet our requirement. Many states in India have got centers of excellence, which I was telling you earlier about. Kerala still doesn't have even one center of excellence. So there are many ways in which Kerala is behind other states like Delhi or Haryana or Tamil Nadu. So many other states have gone ahead. So there are Kerala is the leader still, doing so many things which other states can't do, but still there are so many areas where Kerala needs to catch up with other states.
There's a long way to go, but still we hope Kerala we will be able to reach the targets and achieve the TB elimination soon. Considering your experience in evaluating the NTEP program across different states in India, how would you rate the level of difficulty in implementing the program and conducting the evaluations in Kerala when compared to the other states?
I think evaluating is easier in Kerala. There is more of transparency, data maintenance is good. We have good systems in place, so that way evaluating is easy. The difficulty in evaluation obviously is that we have to go for indirect measures. So, like if you go to Tamil Nadu, because they have a national institute there, the NIRT there. So NIRT was the leader in doing the national TB rural study. And later, after that study was over, they went ahead and started doing district level prevalence studies for Tamil Nadu districts. So lot of information is available in states like Tamil Nadu and all, where the prevalence and other estimates are really being made based on field level studies. Whereas in Kerala, we work in an information vacuum. We have not really done too many studies. It's only in the recent past that we got some information on the proportion of TB infection in Kerala because of Dr. Aparna and study and another study that we did for validating the CTB antigen, which gave us some information. So otherwise, we would not even know what proportion of our patient is infected, what is the prevalence, what is the proportion of MDR. We don't even know. So we are still going with the notified data of the. You can't even call a surveillance data, routine surveillance data, because there's a lot of gaps there. So the disadvantage, obviously, in doing a proper evaluation is that we don't have that much of information in Kerala, which can allow for good policy decisions. On the other hand, the advantage is obviously that there is more of transparency. Our staff are more willing to, bring out information, and the system is so good that we can actually do a proper evaluation.
Let us hope that the state overcomes all its hurdles. Looking ahead, what are some key research priorities in field of tuberculosis, and how do you envision your work contributing to addressing these priorities?
So I think again, if we go back in terms of TB being eliminated or whatever, there are two key things where which are needed. So at the end of the day, if you want to get rid of TB, there are only two things you can do and you should be doing. One is diagnosing cases early. The second thing is treating them, because that is the only way of making them non-infectious and preventing the spread of TB. Now, TB people do not stick to treatment, so you need strategies for uh, case holding also. So that is the way you have to go. Now, each of these two major areas have a lot of areas where you could go in for operational research. One of the big things which is coming up in India right now is artificial intelligence. I think you had a session on that earlier. Now, AI in TB is coming up in a big way. So chest X-ray and AI, about it. So AI for diagnosing TB on X-rays has come up in a big way, already implemented. The government of India has got big plans of having uh, X-ray read by artificial intelligence, because that is the area. But then you should understand that to read X-rays by artificial intelligence, you need the X-rays to be taken in the first place, which is a major challenge for us, and even in a state like Kerala with resources. So now technology is coming up in a big way with handheld X-ray machines. Many states have gone ahead and they got van-mounted X-rays which can be taken to the periphery. So, innovative strategies for case finding and treatment. Case finding obviously are needed. Technology is also helping in terms of more and more of molecular diagnosis. Newer and newer molecular tests are coming up. Um, we even have whole genome sequencing, which is being validated. Technology is becoming cheaper, so many of these tests may be readily available. There are many technology which are still needed, but maybe we are not able to use. Like, if I can give you an easy example, that is a gene expert XDR cartridge. So currently, to diagnose INH resistance, which is a very important determinant of good treatment outcome, isoniazid resistance is diagnosed by line probe assay, and often that takes 2 to 3 months for the results to come, and by then the patient would have finished half of his or her treatment. Whereas if you have an XDR cartridge, you could have diagnosed INH resident within 2 hours. So such technology is also available, which could actually make a huge difference in terms of diagnosis and offering the right treatment for patients. In terms of treatment, newer regimes are there, newer drugs are there, so easy implementation of these things is something that can be. So there are multiple RCTs running all over India on these newer regimes, newer shorter regimes, and all that. Of course, that is not the area of expertise for our state because we don't have that kind of institutions which do a lot of RCTs. But our expertise is in terms of case holding, in terms of patient support networks. How can you ensure that patients get good care? Why is the mortality so high in Kerala? I mean, how do you ensure that differentiated care? And because we have the right institutions with all the facilities available, so how do we ensure that our patients get the right care, and how can we reduce mortality and spread of TB? There's also the fact that some of the newer things which are coming up, which worry us, people working in TB is, for example, if I give you one example, uh, in my hospital where I work now, Thrissur Government Medical College, a significant proportion of patients who get admitted here are homeless people who are on the streets of Guruvayur. Now, Guruvayur is a temple town of Kerala with a large number of people coming in. And once these people get better, they go back to Guruvayur, they live on the streets, they mingle among all the pilgrims, and they don't take treatment afterwards. So they continue to spread TB. So it's a huge number of people who are being exposed to this group. The numbers may not be that big, but the numbers are significant. So poor homes, care homes are having a lot of TB. Prisons are having, many states have got projects which look at TB in prisons, TB in slums. Those areas are something which you need to take up. So there are operational issues there. And how do we do it? So do we need to look at other models of care? So Kerala at one time, I always tell my students that the college where I teach was an old TB sanatoria. So now there is no sanatoria there. Pariyara Medical College was a TB sanatoria, which is again closed. Trivandrum had a TB sanatoria at Puducherry Kota, which is now a chest disease hospital. Still, there is some place for TB. When I was working in a Taluk hospital in Chalakudi, I had a 14-bedded TB ward. Now all those wards are closed in Taluk hospital. No district hospital, no Taluk hospital in Kerala has got beds for TB. So if a poor TB patient needs facilities for IP care, they just shunted around. There is no place where a TB patient can go to care except for 3 or 4 centers in Kerala. That's a huge tragedy for patients, and that may be one of the factors related to mortality. Now, the other big aspect obviously is TB preventive therapy, TB infection. The new technology which we have already validated for the country is called CTB. The antigen is now being procured by the government, so that is going to make a huge change in terms of capacity for testing. So we'll be able to test more people for TB infection. And some of the regimes that we started, the INH rifampicin regime, 3-month daily INH rifampicin regime, which no other part of India was implementing, because of the Kerala experiences now being expanded. Now we need to look at two things which we have not done in the past, which is very important. One is what happens to TB patients after they are cured, because the National TB Prevalence Study showed that 25% of the TB patients in India occur in patients who have been treated for TB in the past. So 1/4 of our prevalence is from patients who have been treated in the past. So it makes a very good sense to actually follow up all the patients who have finished treatment. The guidelines say that every patient who's cured should be followed up for 2 years, but that is not really happening in the field. And for TB preventive therapy also, people who've been treated for TB infection should also be followed up for 1 or 2 years to find out are they actually breaking down to TB. Now, these are things which are not happening, which are again areas for operational research. So there's so much of scope for interesting operational research, which will not only guide the state, it will also guide the country and many other similar developing countries in the world. So there's a lot of scope for both Kerala and the rest of the country.
So that was really enlightening, sir. Lastly, given your extensive experience and leadership roles in TB control and pulmonary medicine, what advice would you offer to policymakers, healthcare practitioners, and researchers working to accelerate the progress towards TB elimination and improve the respiratory health outcomes globally?
Yeah, I guess, one is we need innovative strategy, which Kerala is already doing, but then often these strategies are not getting properly evaluated. So, each of the strategies should be evaluated, and we should look at the pros and cons of strategies. So, the next time a strategy develops, we know what went wrong and what should be new. The past, for example, if you take the private sector involvement in TB, each time a new strategy comes with a funding agency or a international NGO supporting it, after some time, the funding stops and that NGO withdraws and that strategy dies a slow death before somebody else comes with a new strategy, which may be the same strategy with a new name. So that cannot happen, that you keep on, reinventing the wheel. We need to really evaluate each of our moves and find out what is right and what is wrong, which is where policymakers can take an important role. You should look at each of the strategies which have been taken up, look at it critically, appraise them, evaluate them, and find out what is good about them and what needs improvement. And based on that, the newer strategy should actually build up on the previously occurring strategy. One of the things which worries people getting older like me is that we often forget history. And the moment you start forgetting history, you will make the same mistakes all over again. Now, in terms of specialists, there's so much new happening, so much to learn. Often people get complacent, both the public health specialists and the clinician, that we know everything about TB, but then there's so much new. In fact, I get worried when I go for talks that I'll face questions to which I don't know answers, because there's so many new things happening. And as an examiner, I'm valuing answers. I need to check up to find out whether actually the candidate has written something very new which I have not read, maybe which I am thinking is wrong. So there's so much of fast development happening in TB that we all need to keep on updating ourselves, and need for updating sessions and all that. Uh, the last bit you asked something I wanted to add. What was the last part you asked?
What advice would you give to the policymakers, healthcare practitioners, and researchers working to accelerate the progress towards TB elimination and to improve the respiratory health outcomes globally?
Yeah, so the last part was the respiratory health. So the other thing is that, in between we had something called the PAL strategy, practical approach to lung health. So one of the things is that if you take a presumptive pulmonary TB, somebody who has the symptoms of TB coming to a health system. So we had something called the practical approach to lung health strategy, which the principle is that if I come with cough more than 2 weeks and I go to an institution, immediately the doctor is good. The doctor thinks that I might be having TB and then offers me a smear microscopy and X-ray and whatever. But if after that, if I don't have TB, often what happens is I'm just told that you don't have any TB, you're okay. But then I went there with a respiratory symptom. As long as you don't address that symptom, the next time I would have a symptom, I will not come to that institution, not come to that primary health center, because all that the doctor will do is look at whether I have TB or not, will not evaluate me for the other disease. So the practical approach to lung health strategy said that if you give care for respiratory illnesses, patient coming with cough and other symptoms, if you give good care for the respiratory pneumonia, for COPD and all that, more and more people will come seeking care. And when you have more people seeking care, you will diagnose more of TB. So that is a very simple and very interesting principle which actually works. So that way, something that we could not discuss earlier is that in Kerala, we were the ones who pilot tested the practical approach to lung health strategy for Kerala. And later now we have something called a SHWAS program, which looks at COPD and asthma, which is not there in any other state in India. So any strategy which deals with respiratory diseases as a whole, provides good care for respiratory disease, will also lead to more patients with TB approaching for care and for getting diagnosed. So one of the major findings of the National TB Prevalence Study was that in many states of India, almost 80% of people who have the typical respiratory symptoms which should lead to investigation for TB do not go to a doctor. They sit at home. So they continue to work, they sit at home. So there must be so much of spread of TB happening in such population. So for people to seek care, they should be made to feel that they will be provided good quality care. Only then they will seek care. This proportion was much higher in Kerala. So almost half the patients in Kerala were seeking care as opposed to the rest of the country. But still, half is not good enough. You could actually get everybody to seek care, and then you could actually improve the diagnosis and care given to TB patients. So I think overall emphasis on lung health improvement will also lead to a lot of gains for the TB elimination strategy.
Thank you so much, sir, for sharing your valuable insights and expertise with us today. Your contributions have been incredibly enlightening and will undoubtedly benefit our listeners too. We are truly honored to have had you as our guest on Scientia. Thank you once again for sparing this time from your hectic schedule. Thank you so much, sir.
Thank you for the invitation. Good day.
I am your host, Dr. Dency Davis, signing off. Do rate our show and drop your valuable feedback in Spotify, and like and subscribe to our show in YouTube. Thank you and have a nice day. Thank you.